was that?
Good evening, everyone. Hope everybody can hear me well. Hear me okay? My name is Giusti. I'm a transplant nephrologist at the rank of associate professor at the University of Colorado. And tonight we will be talking about the novel therapies for focal segmental glomerulosclerosis and the role of lipid apheresis. The topic will be presented by Dr. Joshua Zaritsky, a pediatric nephrologist from Phoenix Children's Hospital. So Opus Medicus designates this course for a maximum of 1.0 AMA PRA Category 1 credits and ABIM maintenance of certification points. Physicians should claim only the credit commensurate with the extent of their participation in the activity. I want to encourage everyone in the audience with questions to please enter them in the Q&A section, and I will at the end make sure that Dr. Zaritsky is aware and is able to address them. So with that being said, I'll let Dr. Zaritsky start his talk.
Great. Thank you very much, Dr. Giusti. Let's get started. So, what we'll be talking about today is just briefly, and I'm sure the audience is aware of some of the epidemiology and clinical attributes of FSGS, the abbreviation for focal segmental glomerulosclerosis. We'll also talk about some of the what's available to treat FSGS, just ever so briefly, because I want to spend some time on lipid apheresis, and sort of that's the main part of the talk, to talk about its potential mechanism and its efficacy as a treatment for FSGS. So I think, just looking at this slide here, people very quickly have an emotional response when you mention FSGS if they've spent any time treating it. And we've spent so much time talking about this disease, but still it's a descriptive disease. We call FSGS based on what we see under the microscope. And that really goes to the fact that we still lack an understanding of the pathophysiology, although now we recognize it's a disease of the podocyte itself. I think the most frustrating thing about treating this disease is that the lack of diagnostic tools that are used to guide treatment. And in some ways, especially for those patients that don't respond to a myriad of treatments, the so-called cure can be worse than the disease. Also refer to this phenomenon of now what, when I train a new resident, a new fellow, a new nurse practitioner about FSGS, you find yourself treating the disease with one treatment after another, and eventually, in probably around 50% of patients with FSGS, you reach a point where now what? And then the worst, especially for pediatric patients, is this idea that, or the concept that we see a very high recurrence rate post-transplant. That is, you've already had to deal with the disease. You already have post-traumatic stress, just treating the disease, dealing with its morbidity, and then you get a brand new kidney and the disease comes back in a flash. So those are really the things that really sort of at least prompted me, and I'm sure it prompted people in the audience to really say, hey, what is out there that we can use to treat FSGS? One of the problems with FSGS being a descriptive disease is we recognize there's a huge heterogeneity of the disease, that the kidney can only respond to injury in very limited ways. And we see it as patterns of disease, whether it be membranous or FSGS in this example. And what we're going to be talking about tonight is the FSGS, the idiopathic FSGS, that the stuff you see over here on the left-hand side of the slide, basically a likely immunological attack on the podocyte, right? That then causes podocyte damage, leads to proteinuria and this pattern of disease. Obviously, there's other forms of FSGS. All the way on the right-hand side, we think of hyperfiltration as a model. And then also, very rarely we're able to identify a genetic factor. Usually, we're up to 50 or 60 genes that once present in the podocyte cause the disease. And while the genetic diseases are extremely rare, they've been very fruitful in helping us not only figure out the pathophysiology, but designing new treatments. So, and then I've already gone here, at least in pediatrics, a lot of times I have to call Dr. Giusti and say, hey, I got this case. You treat 100 patients with this disease. I treat one. But FSGS is one of those rare diseases where probably, I'll say, pediatricians, pediatric nephrologists have more experience than their adult counterparts because we see it in its purest form more often. And if you look on the right-hand side, you look at Napratix data, one of our large kind of collaboratives. It's a single line item. It's the number one cause of end-stage renal disease in children, right? And then factor that in that we have a 20 to 30% recurrence rate. You can imagine the burden of disease we see as pediatric nephrologists. Then, unfortunately, it's a disease that's not getting any better. We're seeing an increased frequency of FSGS in our children over the last couple decades. We've definitely, I don't know if it's better recognition or better understanding. We've seen a marked frequency in African American children. We wonder also if obesity and hypertension are contributing to the development of the disease. And there, I've mentioned that genetics has really been a boon for us, at least in identifying some of the genetic forms of FSGS, but also giving us a little bit more insight into pathophysiology, which we don't necessarily have time to talk about today. This just reminds you of the KDIGO recommendations, not that we necessarily follow them blindly, but a new patient, you treat them with corticosteroids, start an ACE and ARB for supportive care, and then most patients move rather rapidly to a CNI, right, a calcineurin inhibitor. About in our hands in pediatrics, about half the patients will make it to the left-hand side where they achieve a partial or complete remission. And then you're left, well, how long is the patient going to stay on CNIs? How long are they going to tolerate it? If they do not hit remission, your choices are very limited. They're very limited. And you can see some of the options listed in the KDIGO. Basically, things, once you see something like consider enrollment in a randomized controlled trial, you're in trouble. The good news is, and I used to keep track of all the FSGS studies going on, especially with drug. I almost can't keep up these days because there's so many novel agents coming out. And one of them that, before I get there, I just want to remind you that this idea that treatment is entirely empiric, right? So as nephrologists, we're very good at coming up with very complex ways of explaining complex things. This is a very complex figure about how you would treat FSGS, and you have methylprednisolone, some of the calcineurin inhibitors, what you would add in together, and you see this fancy graph here. But there's nothing guiding you one way or the other, right? It's empiric treatment. And then unfortunately, when you look over the course of all these variety of treatments, there's a lot of red there. That is, most patients, or at least 50%, really are unable to achieve a complete remission, which is very unfortunate that you're exposing them to empiric treatment that is often ineffective and has side effects. So talking about drugs, this is one of the drugs. I need to update this slide eventually, but it serves this point in that basically sparsentan, which is now FDA approved for IgA, shows some effectiveness in the treatment of FSGS. And I wonder if this is going to be one of the newer drugs that becomes available as a drug to treat FSGS. And then I think most of us are involved in some other trials out there that are looking at novel agents to treat FSGS. So, my hope is, in 10 years, I'll be able to show you some successful outcomes of drugs and maybe even have some success as far as pointing towards the epidemiology, pointing to who gets what treatment, right? And of course, at the end of the talk, I'll give you some insight into how do you figure out who's going to respond to what treatment. This is a reminder for me and for you guys that just because someone presents some anecdotal data and puts a lot of force behind it, necessarily you should believe them. And to me, it goes back to even way back when we were started to use abatacept and how promising the drug looked initially for the treatment of FSGS. But when we moved over to clinical practice, we really did not see the success. So I'm tempering my enthusiasm up front with lipid apheresis. I'm a big fan of lipid apheresis for treatment-resistant FSGS by the fact that we have no randomized controlled trials. We have some trials going on, but nothing. So I'm just putting just pumping the brakes there for a second. It's more of a reminder for myself. We'll take a step back and recognize that with FSGS, we've been searching for something called the permeability factor, at least a subset of patients. And this slide sort of says it all, in a sense. This is almost a thought experiment that was carried out where a patient, and you can see patient 1, a history of FSGS, was transplanted, and you see had immediate recurrence of disease. That is, if you look at the red line, you see an immediate recurrence of severe proteinuria. And then more importantly, or more significantly, the kidney function in the blue line never picked up, right? The patient underwent plasmapheresis. And then amazingly, at day 14, where they realized sort of the writing was on the wall that this kidney was not going to work in this patient, they took the allograft out and put it into another patient who did not have a history of FSGS. And immediately what happened? The proteinuria resolved and the graft started working. And there's actually a pediatric case study where a pediatric patient was anuric for a month. They took the kidney out and gave it to another person, and it worked. And this is the idea that there's something inherent to the host, a permeability factor that is intrinsic to the host that immediately attacks the kidney, something circulating that immediately causes this post-transplant recurrence. And this also, gave, and I think most of us feel that, therapeutic plasma exchange is the treatment of choice in this post-recurrent FSGS. And you can see here, what do you see? Plasmapheresis, right? The first several days. The thing about plasmapheresis is that when you go to the Bible of plasmapheresis and look at how to treat it with how to treat FSGS with plasmapheresis, you'll quickly recognize that there's not a lot of good data. There's no randomized controlled trials. There's several case controlled trials, and of course, we all have practical anecdotal experience, right? But I'm just reminding you that the remission rate is somewhere around 50%. So again, flipping a coin. And one thing I want to point out to you is that why, if apheresis carries a grade 1B recommendation for recurrent FSGS, right? Why does it carry a 2C for the native kidney? I mean, essentially, these two should be very similar, but they're not. And one of the things we're working on is getting this idea of moving lipid apheresis up, at least having better evidence support its use, at least equally to TP. And I'll show you some of that today. So I'm not going to spend a lot of time on the FSGS permeability factor just because it's a long story without an end, at least now. The actual solubility factor came out of the Savin lab, who for years studied had an in vitro assay that exposed rat glomeruli to the serum of patients with FSGS and caused those glomeruli to sort of become very permeable to albumin. There really hasn't been anything identified for a while. We got very excited about SUPAR. Could SUPAR be that marker, that pathogenic factor in patients with FSGS? And I'm just showing you some older data now looking at levels of SUPAR in patients with FSGS, and in some large cohorts, they noticed patients with FSGS. And I still remember when we presented one of the initial SUPAR papers where they were able to provide a cutoff saying, hey, if your SUPARs were over 3,000, you might respond to apheresis. Unfortunately, once again, just like with the abatacept, that initial excitement wore off when they were unable to replicate a lot of these findings in other studies in other people's hands. There are still some believers out there for SUPAR as being one of the pathogenic agents of FSGS, but it still hasn't really worked out. So, and then this just shows you this slide I like so much because it shows you where we are compared to 30 years ago in investigating the pathogenesis of FSGS. And this is an amazing study where they basically took peripheral blood mononuclear cells from patients with FSGS and basically transplanted them into mice, and were able to create, using those cells, a mouse that had FSGS. And talk about a way of studying the disease. These mice, right, developed proteinuria, had very high SUPARs in both their blood and the urine. And the thing is, now we have better tools to hopefully study why one treatment would work in a patient versus another. And I'll actually end the talk with some of that. Okay, I'm going to shift gears now into one of the potential treatments of FSGS, which is the liposorber system. It's actually FDA approved for treating familial hypercholesterolemia and carries another HD, a humanitarian device exemption for treating FSGS. And I'm just showing you the components of the machine, a machine that if you're used to hemodialysis, looks fairly similar, along with a filter set. And the machine was designed to bind positively charged lipoproteins. And I'll show you that on the next slide. But how does the machine work? It's basically filtration-based apheresis, where blood is withdrawn from the patient, it's heparinized to keep it from clotting, run through a very high efficiency filter, which separates out plasma. Plasma here in the yellow is then run through a column. And this is where the action has. And note what's happening here, as opposed to apheresis, where you just throw out the plasma that you've separated out. Here, we're returning it to the patient. We've filtered it. It's called selective apheresis. What's in the filter? Well, the filter has a bunch of cellulose beads with dextran sulfate attached to it. So they're able to bind, they were designed to bind positively charged lipoproteins. Positively charged lipoprotein. So why lipid apheresis for the treatment of FSGS? This is the data largely from Japan that came out, which obviously we see hyperlipidemia in patients with FSGS. They treated a couple of their patients with FSGS with lipid apheresis to lower their cholesterol. And indeed, some of the patients went into remission. And what I'm going to focus on is one paper, the Hattori paper. It's an older paper, largely retrospective data, but this was used by the company to present evidence that perhaps lipid apheresis could be effective in treating FSGS in the United States. And this study was 11 pediatric patients with biopsy-proven FSGS, non-responsive to prednisone and cyclosporin, the calcineurin agent at the time. And you can see there, right, very classic, right, degrees of proteinuria, serum albumin, their prior treatments. And they all underwent a very similar treatment course. And I'm going to spend 2 seconds on this slide because this is the treatment course that most of us use now to treat either primary FSGS or post-transplant recurrent FSGS using the lipid apheresis. So we sort of have an induction phase where we have 2 sessions a week for the first 3 weeks. Then we move over 1 session a week for the next 6 weeks. So a total of 12 treatments over 9 weeks. And in this particular paper, although it was retrospective, everybody sort of followed the same treatment guidelines. And what they ended up doing was reintroducing steroids to the patient, even though the patients were clearly steroid resistant in the beginning. So just take a mental snapshot of that. I'll remind you of it in the future slides, because this is much what most of us have used now. And here you can see in the first 9 weeks of treatment, right, this largely previously completely treatment-resistant group, 7 out of the 11 patients went into remission. 7 out of the 11. And you can see that basically here, anybody with a circle achieved some form of remission. And not unexpectedly, 4 patients showed no effect, right? But keep this in mind when you look at this next slide here, where they had, even though it was a retrospective study, they had some long-term data. And not unexpectedly, and compared to this follows our clinical practice, if you're unable to get into remission with large degrees of proteinuria, really there's one thing written on the wall, right? End-stage renal disease. But what was unique about lipid apheresis in this treatment group is one patient eventually went to end-stage, a partial responder. But look at these patients who had complete response. We had patients at 11 years out who were still had their native kidney function, right? So there's a lot of problems with the study, small, retrospective. But one of the hardest things is there's really no true mechanism that comes out of the paper, which we'll talk about. But there was still, again, nothing that really predicted a response to treatment. They did recognize people who had worse biopsies starting off tended to do better. There was something about the selectivity of the proteinuria, which we've kind of left behind. Higher was better. There was only one complication, a line infection, small numbers. You could make an argument, what about spontaneous remission, which I think most of us would say that just doesn't happen in patients with severe FSGS. And then what is this idea of the prednisone response? Why do these patients why do you have to have prednisone kind of mixed in for the response? And this paper gives, or the reviews that follow this paper gave a whole laundry list of mechanisms, right? And as physicians, as caregivers, we want to give a mechanistic reason. We're still not there. These are some theoretical. Probably the one that's most favorable, if you've been listening, is this idea that somehow the filter absorbs the vascular permeability factor, right? Could you imagine if I could treat the patient get that permeability factor out somehow and allow the patient to somehow allow the patient then to keep their native kidney or keep their transplanted allograft. We also recognize that, another example, potential mechanism is that, the calcineurin inhibitors compete with lipoproteins to get into the cell. So maybe, in the cell that it matters, we're able to get higher levels of calcineurin inhibitors in because we're able to lower lipoproteins via lipid apheresis. But this is sort of a laundry list without a proven candidate or leading candidate. And that brings me to the fact that for a long time we've sort of ignored the link between disordered lipids and CKD. Right? We recognize that there's a complex interplay. Certainly CKD is not good for your lipid profile, and lipid profile is not good for renal disease, and we can reach this kind of vicious circle. But this paper, along with a preceding paper, really suggested for the first time that perhaps some of the pathophysiology we're seeing is related to abnormal lipid metabolism. That is, the abnormal lipids we see, maybe that's just not a side effect of FSGS, but it's actually contributing to the disease. And this is a great paper to read, and it basically shows and demonstrates why we see very high triglycerides in patients with FSGS. And essentially, it goes like this: is that you lose a lot of albumin, obviously, with FSGS. Albumin normally it binds free fatty acids, and so as your albumin drops, what happens? Your unbound free fatty acids go up. This causes the rise in an enzyme called angiopoietin-like 4, which inhibits lipoprotein lipase, and that leads to high plasma triglycerides. Explaining mechanistically why we see high triglycerides, it kind of makes sense. You have high free fatty acids, you don't need to cut up triglycerides as much, right? This paper then went on to look at, could angiopoietin-like 4 be pathogenic itself, causing damage to podocytes? And they present a picture where essentially the stress of FSGS, by pushing all this albumin across the podocyte, causes this maladaptive response by raising angiopoietin-like 4 and causes podocyte loss and destruction. And this makes sense, right? What is FSGS but ongoing podocyte damage? And essentially, it doesn't matter what triggers the initial event, but once you get that increase in the free fatty acid to albumin ratio, you have a maladaptive response and this persistent podocyte damage, right? And when I first read this paper, I was like, this line here, right? Therefore, lipid protein apheresis to lower lipid levels could reduce proteinuria and improve renal function. This is an idea that by treating perhaps an underlying defect in lipid metabolism, you could then alleviate that maladaptive response that just grinds on in FSGS. And of course, this is still a theory, but I'm going to show you some interesting slides at the end. So in a sense, nephrotic syndrome represents a common endpoint for podocyte injury. It doesn't matter that there could be 1,000 points, right? But at the end, what you want to do is cut off that maladaptive response by tampering down levels of free fatty acids, for example. So you might be even able to treat congenital nephrotic syndrome or a genetic form of FSGS, or keep that kidney working longer if indeed abnormal lipid metabolism is at fault. And of course, the story is a lot more complicated than that. One of the groups that initially described this basically described two forms of angiopoietin-like 4, one that's modified in a different way that is produced by peripheral tissues, and one hurts the podocyte and the other does not. I don't want to oversimplify that story. And to be fair, that story really hasn't led exactly to a novel treatment. So I'm just going to flip real quickly again, make another change here and talk about the HDE, or humanitarian device exemption. So when Kanika came to the FDA and said, hey, we want basically to trial this machine in the United States, the FDA said, listen, there's fewer than 10,000 patients with FSGS. This is the mechanism that you have to use. This is a humanitarian device exemption, where essentially the FDA is saying the treatment is safe. And they're basing that on 20, 30 years of treating using patients with hyperlipidemia treated with lipid apheresis, but the effectiveness is not known. And the HDE comes with these kind of considerations of who is eligible for treatment. And you can see it's also part of an ongoing study, a post-approval trial study in both pediatrics and adult, looking at patients with FSGS. So to be included for primary FSGS, you have to have a GFR greater than 45, and then any of the following. The real one is there, that refractory nephrotic syndrome, in which standard treatment options are unsuccessful. That is, most of the patients I've treated, both pediatric and adult, come to me sort of at the end of the line when someone asks, now what? Then they give Dr. Zaritsky a call. There's also a treatment arm in both pediatrics and adults to look at patients who have recurrent disease. That is, anybody with recurrent disease can get into the trial. And this is the protocol. It's very simple, basically. Again, you'll see there the 9 weeks of study of apheresis, 2 treatments a week in the first 3 weeks, 1 treatment a week for the 6 weeks, and then regular follow-up. And I'm going to just show you my clinical experience with the trial. I had 2 patients that I had treated, both with horrible treatment-resistant FSGS. Both showed an initial response in the sense that both of their weights dropped. I was able to just all of a sudden spontaneously, not spontaneously diurese, but these patients were able to diurese. One patient in the blue stayed in remission, just like the Hattori paper I presented. Unfortunately, the red patient there immediately recurred. Now, initially, when we were doing the study, we did not include that steroids that seemed to always be part of that Hattori study there. And so I thought, well, maybe I'll be able to maintain this patient using a fistula with just regular treatment. I'll keep him here with lipid apheresis, maybe 1 treatment a week, something like that, 1 treatment every other week. So I had the surgeon put a fistula in, and then the surgeon's like, what are you, fistula? And someone who has FSGS, what are you doing? And just to prove to myself that the patient had responded, I said, let's retreat the patient, get him back into remission. And this time I used steroids. And believe it or not, the patient went into remission and stayed in remission. So that was the best fistula that I ever asked a surgeon to put in that I never had to end up using. And this then we took that data, that I'll say anecdotal experience in our hands, and kind of then started treating our treatment-resistant patients who had FSGS, secondary FSGS. Those were primary FSGS patients. And this is the first patient that I ended up treating. Note, this patient came from an outside institution, had very high protein and creatinine ratios. Note the log of the protein and creatinine ratio. Were treated with rituximab, treated for quite a bit with apheresis. And then once I so-called got my hands on them and treated them with the standard sort of lipid apheresis protocol, they went into remission and stayed there. And this was sort of eye-opening for our unit, where then we started treating all our patients. And we were able to put together, these are just several more examples. You can read the paper by Shaw et al. In pediatric nephrology. And we were able to include 4 centers, our center, Cincinnati, and 2 centers in England, to basically use the same protocol. And every patient, of course, in the beginning, everything works perfectly. 7 out of the 7 patients all went into remission. They all had a similar response. And this shows you, the post-transplant therapies used prior to LDL. You can see abatacept was listed there. Some patients got cyclophosphamide. I want to point out, though, some of the patients had been on apheresis for an extended period of time, right? And I just want that, just that, sometimes we just do apheresis because we don't know what else to do, and we're sort of treating the albumin. The patient's going to apheresis and getting 5% albumin to get their albumin up. But look, this patient had been on treatment for 18 months of apheresis, right? And we were able to take that patient and convert them, put them into remission with lipid apheresis. So, and this at the end of the paper, we looked at their eGFR, and it was sustained, essentially sustained. And then we haven't published this data yet, and we're actually getting together with another center who has had success pre-transplant, right? So now I'm working at Phoenix Children's, and when I got there, we had a whole bunch of patients who were suffering from primary FSGS. And once again, we're able to kind of leverage that same protocol, and you can see, once again, in blue is the albumin, and orange is their protein to creatinine ratio. And you can see, for whatever reason, it's just, you'd rather be lucky than good. But our first 4 patients that we've treated all went into remission for pre-transplant. So, what am I looking at the time here? Ooh, I've gone too quickly, believe it or not. Maybe. Uh, so, um, this is what everybody wants to know, right? What are the mechanisms that underlie the potential usefulness in lipid apheresis in FSGS? That is, why does FS why would lipid apheresis work in FSGS? And I've given you a potential model, right? This idea that if I'm able to normalize lipid metabolism or perhaps lower the level of free fatty acids, that I'm able to reduce an ongoing injury to the podocyte, right? So how do you study that? And so we've now partnered with a group in Boston to look at this. And essentially what we've done, myself and another group, we've been biobanking samples. That is, we've been collecting serum pre and post lipid apheresis during the trial so that we have quite a bit of plasma banked up for patients who have been treated. And I have to mention that not all, since my first success, we've definitely had patients who have not responded to treatment. And now what we're actually able to do is to look via two mechanisms to see by looking at if we extract, first of all, if we look at the plasma and serum lipidomes, right, before and after lipid apheresis, we're able then to focus exactly over here on the left, which lipid species are specifically depleted and altered after the cycle, right? And also to pair that up in patients that, compare patients who responded to haven't responded, is there a particular change that we see that predicts a clinical outcome? Or is there, let me say this, is there a particular lipidome, even before treatment, that can then be used to say, hey, this patient A, is going to respond to lipid apheresis, whereas patient B is not going to respond. Okay. That's also going to be used now in this, it's an amazing in vitro toxicity assays, where, and I'll show you, and I can't really do it justice compared to how the guys in Boston can, but basically they extract the lipid fraction of the plasma and expose podocytes to it. So it's an in vitro toxicity assay. It's almost like a very ramped up solubility, that when they were looking for the solubility factor, ramped up several fold to look at, do we see something that's being taken off by lipid apheresis that itself is toxic as a lipid that's toxic to the podocyte itself, giving us a better idea of the pathogenesis of the disease and why the treatment works. So we've kind of worked in reverse, right? We found a potential treatment that works, and then by studying its mechanism, can we learn more about the pathogenesis of the disease? And this is just some slides here looking at in an in vitro assay where they have this differentiated immortalized mouse podocyte cell line. And you can see they're able to treat the podocytes, right? And you can see they have a negative control with BSA down here, right? And they're able to, let me just move this out of the way real quickly. But you can see they're able to look at, compared to different podocytes, and they call them, medium chain and long chain MUFAs and PUFAs, they're able to start to look at in vitro, right, effects of a variety of individual free fatty acids, how they affect the podocyte. How, like, for example, these two look very similar, right? That this clearly this free fatty acid is not hurting the podocyte, where this one is causing quite a bit of podocyte damage and death. So we're just hoping that by looking this biobank that we have on our patients, both pediatric and adult, is now we'll be able to go back and say, hey, what is the mechanism that underlines the potential usefulness of lipid apheresis? So to me, this is very exciting because I have been pushing this idea without any real data for a long time. I'm a clinician of that there's something wrong with lipid metabolism. If we could just fix it, we could fix FSGS. I know that's not going to work in every patient, but in a subset of patients. The next slides are a little bit, they're hopeful, but a little bit disappointing in the sense that in pediatrics, we have a very nice outcome collaborative called IROC. It has 15 transplant centers, and you can see as of October 22nd, 2022, which is now almost 3 years ago, or 2 years ago, had almost 3,700 active patients. And so it serves as a great, big collaborative for us in pediatrics, right? And obviously a great target for studying patients with FSGS. And it covers 61% of the patients who are transplanted. And our hope was initially, and I'm going to page through this fairly quickly, was to basically do a randomized controlled trial in kidney transplant. That is, if somebody in the collaborative had a patient with recurrent disease, right, we would then randomize them to sort of the standard of care at the time, which would be rituximab and TPE, sort of our standard of care, versus the study arm, which would be similar in the sense of rituximab, but would also include LDL apheresis. And there would be an ability for a crossover arm. Whereas if you did not respond after several weeks on LDL apheresis, you're eligible to go to TPE. And patients on TPE who, for example, I've treated before, just stopped on TPE, were able to come over. What's been very difficult, though, and the sort of this is an unfortunate reminder that wouldn't it be ideal if we could do a study like this, lipid apheresis versus TPE. I think even if you're able to do a study like this, you could get some very good data about the effectiveness of TPE in post-transplant, our standard of care that we use all the time. So what's just difficult is unfortunately finding funding for a study like this. We have the patients, we have the protocol, but getting funding to it's a rather expensive trial, and to prove that, hey, show that we have enough power to complete the trial. This has been sort of I used to be very excited about being able to propose a trial like this. We've just kind of ended up not being able to move forward just due to funding reasons. We have like I said, we have the patients, we have the disease, we have 2 potential treatments, but comparing the 2 ends up being more difficult. I think what's going to end up happening, just to go back for a couple of slides here, is that what we're going to have instead is having this both lipidomics along with an in vitro toxicity assay to help focus and to give us a potential mechanism. Why would lipid apheresis work in FSGS? And then that would, of course, prompt somebody to say, hey, I'm willing to study this in a prospective way. So I will summarize that there's many. The good news is there's several novel and now I have to say somewhat tested therapies for FSGS. I'm involved in some of them, some novel agents for treating FSGS, several ongoing trials. The lipid apheresis, I don't know much about the adults, but pediatrics, it's been very difficult to enroll patients. But I think this post-transplant rescue protocol that in our hands has worked very well. And now we've been able to leverage that experience and work in pre-transplant also. And then, of course, I have here, we have a novel trial comparing TPE to lipoprotein apheresis. I have to just be honest, I'm a little bit more excited now about some of these mechanistic studies that are finally going to get done, right? That have the ability to not only help us determine who might benefit from lipid apheresis, to give us a little bit of this, get rid of just that idea that we're just doing empiric therapy, and also give us better insight into the mechanism of action, especially if it ends up being something due to lipids. And for me, what would be amazing is this idea that for so long we've ignored the abnormal lipid metabolism that happens in FSGS. If that ends up being part of the pathogenesis, I think that would be an amazing story. So I'm going to leave you here and we'll take some questions, but this is just to remind you that CME and MOC credits are available online through Opus Medicus. We encourage you to obviously take the quick exam, the evaluation and certificate buttons you have to go through. The slides are up and available for your reference. And then you only need to take the exam, fill out the evaluation, and then you can download a certificate. So you actually get CMAL credits after hearing me kind of yammer on for a while. Okay, I think we're open for questions if there are any.
Thank you, Dr. Zaritsky, for this excellent presentation. I encourage the audience to please enter their questions through the Q&A section at the bottom, or just feel free to ask them out loud. I had a couple of questions on my own, if you don't
Yeah.
mind, Dr. Zaritsky, to start with. For the audience, in institutions where we don't have that LDL apheresis available as part of the research protocol, as you mentioned, through the institutions, how can kidney doctors or providers potentially provide this therapy to their patients? If you can give some of the recommendations.
Yeah, I think the best thing to do, actually, you can always reach out to Canica, who manufactures and provides the equipment, but often the machine is there, whether you realize it or not. And the people using the machine are doctors who are treating hyperlipidemia. That despite a lot of the novel, small interfering RNAs and the targeted treatments, the PCSK9 inhibitors, lipid apheresis still plays a role for treating these patients. So often the machine is there, and you have the people who know how to run the machine. So then getting the HDE, using the machine, so it's already on campus, it's already part of your medical institution. It's just a matter of talking to those people, presenting some of the data, and then depending on how your IRB and your institution works, getting approval to use it as an HDE device. Often that includes the use of the IRB. The IRB will have an HDE exemption pathway for you, which is built in. But in this case, it's a lot easier in a sense because the machine already carries an FDA approval. So it's easy to present the IRB with data saying, hey, this machine is safe. It's just its efficacy is a little bit uncertain. So you're in that unique scenario where you do have to go get an HDE, but it's easier to get because the machine already has an FDA indication. So I will say it's sort of like the machine is out there. You just have to find where it's being used in your institution. Most large medical centers are using lipid apheresis. And I'm trying, for me in a pediatric institution, we had to bring the machine in. But what ended up happening is we did the reverse, right? Where we then started treating patients, since we had the machine up and running, we actually started treating patients with familial hypercholesterolemia, right? And we're able to bring pediatric patients into our unit that had been served in adult units. So that's another. I'm giving you the back end of the story that for even if you do get the machine using it HDE, it's very easy for you to be able to offer the machine and treat patients with familial hyperlipidemia. But I'm not giving you evidence on that. But it's like I said, it's another FDA approved indication.
Indication, yeah. Awesome. Excellent. Another quick question. What type of access these patients usually need?
Yeah.
For the,
So in I find a lot of times with our patients, or pediatric patients, or patients who have had FSGS for a while, they need a central line. They just need a central line to get through the 12 weeks of, the 9 weeks of treatment. That being said, I'm not, you can also use a fistula. I've treated some adult patients with a fistula. So it's very similar access to TPE, well, identical. Now, it is possible for our patients with familial hyperlipidemia to use peripheral access, to use two veins. But for whatever reason, and my practical experience is that once you've had FSGS for a while, a lot of your veins have been used up and it's almost impossible to just use peripheral access. But to each their own. To each their own. Most of the time, especially in pediatrics, they end up needing a central line. So it becomes more of an invasive therapy with that in mind, that there's a catheter in place. But I will say, for the most part, it's a 9-week treatment course. It has sort of an endpoint, whereas TPE often you go on and on and on.
Excellent. Thank you for that answer. One last question on my end, and you might not have the answer, but I'm still trying to figure out, is there a clinical clue or sign that you would use to say like, hey, let's try LDL apheresis first, or let's try TPE, and if that doesn't work, let's use LDL apheresis.
Yeah. I think it's an excellent question. And I think, part of the disappointment, besides not being able to provide a mechanism of action, I can provide some putative mechanisms of action. And maybe a year from now, I'm going to give you some real data. I think the second hardest thing is saying, once again, we're using an empiric therapy, right? And there are no patients that I can say, oh my God, you're going to work on LDL apheresis. You're not. Some of it is just there's a little bit of common sense. If someone only has a GFR below 30 and has a lot of interstitial fibrosis, you recognize that patient isn't going to respond in a way that you would hope they would respond. As far as TPE versus lipid apheresis, I would push back on the statement that TPE is the standard of care. that if I was to give a mechanism of action, if I was to give a similar talk that just focused on TPE, it would sound very similar to what I'm talking about with lipid apheresis. That if I said, hey, what's the mechanism of action? Well, you'd say, oh, maybe you're removing that putative solubility factor, right? Similar to lipid apheresis. And then I would also push back on some of the evidence of what TPE works. And if TPE works so great for post-transplant recurrence, why isn't it recommended? Why does no one do it for pre-transplant, right? You know, so I would push back a little bit. And I have a lot of experience using lipid apheresis, and I also, you know, in some senses, because you're returning the plasma to the patient as opposed to just wholesale dumping it, there's less exposure to plasma products with lipid apheresis. It's selective. It's a selective treatment versus regular apheresis. So I would say you really have to open up people's mind. But, you know, in some senses, when we lack a mechanism, we lack, you know, we lack, you know, we just have an empiric treatment. It becomes very difficult to argue with people like, well, why don't you try lipid apheresis before TPE? You know, this is what I did. This is what I've trained with. You know, it becomes very difficult until people see the evidence with their own eyes. Until we have a trial that compares TPE to lipid apheresis, it's still it's an uphill battle. And I can tell you, it's an uphill battle for me to talk about this when I don't have a great mechanism of action. You know, that's how we kind of work. This is how the drug works. This is how the treatment works. And instead, you know, with apheresis, you know, when in doubt, apherese it out. We're in a similar situation here. So I find that can be very difficult. And even when I've had some, you know, I'll just use a local example here. One of my good friends, colleagues, was, you know, came with me, who started working here with me at Phoenix Children's, and he was I needed coverage, and I got him enrolled in the IRB and everything. And when I really got down, he's like, I don't think this treatment's going to work. And after the first patient, he's like, eh. The second patient, all of a sudden, now the third patient we had, he's like, I think you're onto something. But this was a colleague of mine who, you know, I had explained all the data. There's just that, you know, there's that initial activation energy that when you want to bring change, you have to bring something that's better than what's considered the standard of care, even if the standard of care is not great. It's not great.
Okay. And then one last thing, like the main side effect of concern will be like procedural, like or line infection related. Huh? We didn't see
Yeah,
like any other increased risk of
we've
infection in general.
no, we've had very good success. We see a similar, and I'll say anecdotally, a similar to less side effects than we would see with TPE. Maybe some of that is just due to that you just use it for 9 weeks, whereas TPE, a lot of patients stay on it. But notably, there is a reduction in the exposure to plasma products. That is, most patients on long-term TPE eventually end up needing a little bit of FFP. You'll notice in this case, because we're just returning the plasma, the filtered plasma of the patients, we typically don't see that. We typically don't see that. Now, there are some one-offs, patients who have had reactions to the filter, stuff like that. It's just it's in general a very well tolerated. And if you have a question about that, then at least you can fall back on the 30, 40 years of experience of using it in lipid apheresis. That when you talk for hypercholesteremia, when you talk with your colleagues, hey, what can I expect to see happening? They have a wealth of information based on patients that have been on lipid apheresis. I'll just say for familial hypercholesteremia their entire lives. Right? So there is a wealth of knowledge out there.
And those patients like non-nephrotic or non-kidney related, they usually are premedicated only with like H2, so with
Usually,
Tylenol,
no,
Tylenol and Benadryl.
I don't pre-medicate any of my patients.
Okay.
So there's really no need to pre-medicate. Similar to apheresis, there's a risk of a bradykinin reaction. So you have to make sure your patients are off ACE inhibitors. Very similar to TPE, that there's a chance of a bradykinin reaction, but most of the ARBs are fine. So that's the only thing you want to make sure to avoid a bradykinin reaction. You want to make sure your patients are off ACEs and instead have transitioned over to ARBs.
All right. Thank you for the answers. Is there anybody else in the audience who would like to ask a question to Dr. Zaritsky regarding the LDL apheresis and the treatment of FSGS? All right, thank you. Any other comments, Dr. Zaritsky?
No, I think if you have questions or comments, or you want to get a hold of myself, you can use my first and last name, which are available on the slides, joshuazaritsky@gmail.com. I give that out instead of my Phoenix address, which is jzaritsky@phoenixchildren's.com. And you're welcome to reach out to me. Often, if you want to bring a new treatment, you need a little push, and I can help with that. I can also help with a little bit of sort of the practical experience using it to treat patients with FSGS. So I encourage you to reach out to me.
All right. Thank you very much.